want to use the, I mean, this one you get a bit over. I'm not sure.
I can use the portable then when I
Either
do
one's
mine.
fine.
I'm after lunch anyways.
Portable as well.
Yeah, I can use the portable after lunch.
Oh, yeah, yeah.
Okay. Yeah, I'll use that one, I guess. It's probably just as easy. Okay, great.
Great.
Okay, well, and thank you again for inviting
Well,
me
thank you
in.
for coming. I know it's been, I heard this stalled for 1 or something.
Oh, well, yeah, well, there's always lots going on.
True, I suppose.
There's always lots going on. No, we were just commenting yesterday. We were supposed to have, I did the ECTs with Dr. Babbage yesterday, and we were supposed to have, I don't know, 6, and then we had 4, and then we ended up having 3 at the end. But, you know, certainly.
I don't have a bio.
Oh,
do you want to introduce yourself?
No, yeah, but I mean, you can just say that, you know, I'm a consultant anesthesiologist in Fraser Health.
Okay.
And I'm going to talk a little bit about my background just to say, you know, what's my, how can I actually talk about ECT and what do I do?
Oh, great.
So I'm just going to, you know, so you can just say that, that's fine.
Okay,
Yeah.
okay.
I'll just mention a little bit about
Thank you.
what, you know, what I do and the numbers. Because I was looking at our numbers. I pulled our numbers for the clinic for the last year, and our average is about 38 a month. But we've had some months we've done over 50. So that must be the highest numbers in Fraser Health, I would think, isn't it?
I think so. I don't know the utilizations that
Yeah, well, because at RCH,
as intimately as Heather, but we have actually a slide at the end of the day showing each site.
Yeah, I'm sure that at 38 a month, like I looked at.
Oh yeah.
That's probably the highest, and RCH and Surrey must be about equivalent because we're doing about. We're doing almost 3 every day at RCH. Not every day, but almost 3. So we must be between 25 and 30 a month there.
Oh, okay. So
yeah.
Here is the.
Here's the numbers. Okay.
Slide that we're going to show at the end of the day. I'm not sure how long you're staying, but this is there.
You don't. Oh, there we are. U.S. surgical. So this is percent of what we can do, more than our numbers.
Percent actual usage.
Yeah, percent of intended usage.
So it looks like uniformly Heather's going to just
say that we're all at
we're not at capacity. Well, but I don't know what that means.
Yeah.
I know there's cancellations always. And I don't know.
Yeah, percent of intended usage.
Yeah.
I guess it depends what you're funded for, right?
Right.
Yeah.
And I don't know. That doesn't show absolute numbers. So I can't
no.
either.
Yeah. But I mean, our absolute number. Yeah, this is just percentage of what you're supposed to be doing and what you're actually doing, right?
Right.
Yeah. But.
Interesting.
Yeah, but I think in terms of raw numbers, we're probably doing the highest number.
Oh yeah. The other thing is, we'll be presenting this slide on the.
Okay. Oh, showing
So I think you are the highest. It's 12.
Yeah.
And I think everywhere else the maximum is 9.
Yeah, because Royal Columbian we can do 9 Monday, Wednesday, Friday. Yeah, but we don't. Yeah, exactly. Yeah. So we're the. And we have done 7 on some days at the clinic.
Oh really?
Oh yeah, we can do. I mean, I keep telling you, we can do as many really as you want to do.
Right.
It's just whatever your funding will allow, right?
Well, it's good to see because I think there's the administrators here.
Oh, is it? Yeah.
And Chris.
Oh, are they here? Okay,
and
yeah.
It's good for them to be here.
I mean,
part of the issue is the BMI.
Yeah, but you know that has not been a huge issue for. I can't say that I've had to. I can't say that I've had to turn down a lot of people, and even if the BMI is a little bit over, if they were otherwise healthy, I'll usually take them, especially if they've had a treatment at a hospital and it's been no problems. I'll often take them anyways, because you know if they obviously have a lot of other comorbidities in addition to their BMI, I won't. But you know if it's just like somebody whose BMI is 36 and they're otherwise healthy, and I'll probably do them. Because I think that it's the college, right? That the college doesn't have their guidelines says should, not must. So I think if you can show that there's no other.
Is it the college or the surgical center?
It's the college. The college. If you are receiving a general anesthetic at a non-hospital surgical facility, your BMI is supposed to be less than 34.9. If you're receiving a general anesthetic, but they say should be less than 34.9. And there is something in there saying unless there are no other options kind of thing, right? So
there's an out.
Yeah, there is an out. And so that's, as I said, I will look at the patient and make a decision. You know, like if they're, a 30-year-old healthy person who's got a BMI of 36 and no other comorbidities, I'll probably let them go.
I think if we had other fears that.
Yeah,
I think that's limiting people really bothering.
Yeah.
But if they know they
Yeah.
can refer them to
Yeah,
check
you
it
can,
out.
I will review everything. Now, I know there was a recent patient that one of my colleagues actually saw in the consult clinic and said, okay, let's do her first at the hospital and see how they do.
Yeah.
So, anyways,
Okay.
anyways, there are lots of options.
There's options more
Yeah.
than we think there
Yeah,
is,
yeah.
sounds like.
I'm quite willing to, look it up pretty much most charts and stuff.
Oh, great. That's
Okay.
exciting, actually.
Oh, do you want me to leave my USB there?
Oh, I can take it out now.
Okay,
I think
you loaded it.
Yeah,
Okay.
I just
Yeah, I'll probably just leave it if I don't.
Yeah, me too, actually.
I'll end up leaving it behind. So I'm going to try and keep my talk to half an hour because I want people to be able to ask me questions.
Please, yes, I think there's a lot of questions.
Yeah. So I really haven't gone into a lot of detail about studies and all that kind of stuff because I think people might want to just hear what the practical aspects of what we do
That would
are.
be wonderful.
So I'll keep it pretty short.
We're
Kind of practical people, so we
right, and it's a small group, so there should be a lot of discussion.
Sure. Yeah, I'll do that.
Hopefully.
Great. Yeah, there I am. Okay, perfect. Okay.
Perfect. Thank you. Okay, let's see.
Because when I time myself, I get it to an hour, which I figured about 15 minutes questions. That's with not taking any questions.
Yeah.
Through. And then there are some spots, because I kept all of my residence stuff in consent, which may or not be the right level for this group, right? So there's a spot where I was talking about more like the what you say have to chart, which I can actually probably just pass.
Oh, we mentioned it before, right? I think you could do that because everyone practices.
Right.
What I wanted to inform is, I'll show you. I'm checking the strategy.
Enjoy your afternoon.
There's a lot of material in your.
I know. I'm sitting here trying to figure out where to. There's some stuff that can naturally come out.
Yeah. No.
No. Well, there's some stuff in terms of level, like the level of where everybody's practicing it, that I can quite easily get through.
I certainly think. I mean, maybe this is my ego. I mean, the stuff about consent and the different aspects that's really important.
You know, I actually changed my mind.
Use that.
Yeah.
Okay.
Yeah.
So this button right here activates it.
Okay.
So whenever you're ready.
We're warp 10 now. So Dr. Doyley is a psychiatrist who practices at Vancouver General Hospital. And she's been there since completing her clinical fellowship in geriatric psychiatry at the University of Ottawa. Her clinical practice consists providing inpatient consultation and follow-up for frail elderly patients, clients admitted to the Stats Center at VGH. She also works in the community and is the physician lead for Vancouver Community Older Adult Mental Health and Addictions. Dr. Doyley has a long-standing interest in neurostimulation, which goes back to her clinical rotations with Dr. Gosselin during the UBC Psychiatry Residency Program. She's been an ECT practitioner at VGH since 2002 and is one of the founding physicians of the transcranial magnetic stimulation programs at VGH. Since its inception, Dr. Doyley has also been one of the clinical faculty involved with the ECT Intensive Training Week, which provided for the residents in the UBC Psychiatry Program. Welcome, Dr. Doyley.
So, hi, good morning. I apologize, I have lots of slides. We're going to go through them a bit warp speed because I know that we're short of time and I do really want to have the opportunity for some questions. There are 3 topics that I was asked to speak about today, and I just put the learning objectives up. So the first 2 really are around consent issues. The first is to look at what are the components of valid consent, generally, but then also around delivering a course of ECT. And then the second was actually to look at what the legislation says about consent procedures, because I know in Fraser there are a lot of discussions currently happening, and some of the decisions are really based site by site, and it's based on site preferences, but there are some things that are actually embedded within the legislation. So I thought it would be helpful to separate what the law says from then as you, as a region, are trying to look at what your procedures and policies will be. You can know what's legislatively driven and what's driven by the site. The third topic is, in and of itself, a fairly big topic, which is concurrent medications. Really what I wanted to do was try to give you a little bit of an approach to use, because there's no way that I can exhaustively go through every single medication. I have put in some specific examples, but a lot of it will really be to try to give you an approach to use in reviewing medications. And then finally, the last area that I was asked to talk about is really the geriatric population. For me, that's my bread and butter, and it does sort of color the way that I look at everything above, because it's often a little bit more challenging to get consent from my older adult clients simply because they have more cognitive issues and the capacity issues come up a little bit more often, and they're often really ill, so I'm always dealing with a lot of concurrent medications. So when I started looking at consent, the first issue I wanted to look at is really, when we talk about consent, what is it? What are the components that are necessary to obtain consent? Who do we go to in order to get consent? And how long does the consent last for? So when it comes to consent, I really talk about it as thinking consent is really a dialogue, and it's between you as the provider and the patient or the patient representative. And I really discouraged the idea of thinking of consent as being that consent form, whatever form you choose to use, that isn't sufficient to really be thought of as consent. It's really one step. But even medical legally, if the only thing that's charted is a one piece of paper, and if there's an adverse outcome, you wouldn't have a lot of protection medical legally if that's the only documentation that you have around consent. When it comes to ECT, it even becomes more important to think of it as a dialogue, because it's not like that you're going for surgery on one day and then the procedure is completely completed. The course of ECT can take place over a number of weeks or months if you're looking at continuation or maintenance ECT. And people's conditions and status, their psychiatric health changes and their medical health can change. So the risk and benefits really change throughout the entire course. And so really that consent process is going on continually. So I wanted to really strip back to the basics. So when we talk about consent, we talk about this idea of informed consent. And I really wanted to look at what that means. And this might be a little bit rudimentary, but I think it's always kind of good sometimes to go back to the basics. So when they talk about informed consent, that you're getting consent for the treatment that you're actually proposing, right? So you can't say someone's going for, I don't know, a hernia operation when you're sending them for ECT. That you have to get consent voluntarily. From whomever you're obtaining consent, you have to be getting it from them voluntarily. You can't obtain it by fraud, and you can't misrepresent the procedure that you're trying to get consent for. Number 4 is often one of the more important ones. So the adult or the patient must be capable of giving or refusing consent. And if they're not, then you look to a substitute decision maker. Okay. I would really encourage, for those of you, if you're doing ECT consultations, if that's part of your role, is to make a comment on whether the patient is actually capable of granting informed consent. Okay. If you don't make a comment, the way that the law is written is that people will be assumed to be capable. So if you're silent on the issue, the person's capable. If you make a comment, then you can start to look for other substitutes. And again, this won't be news to most of you in the room, but I really want to separate those ideas of capacity and incapacity from certification status under the Mental Health Act. So involuntary admission or voluntary status, they're really wholly, completely separate ideas. So in the basic principles of informed consent, there's actually nothing written about one's status under the Mental Health Act. Okay? What they only talk about in the principles of informed consent are capacity or incapacity. Part of the assessment of whether someone is capable or incapable is really driven by this point number 5, which is that you as a healthcare provider needs to give enough information that a reasonable person needs, not an obsessive person like me, but a reasonable person would need to make a decision. And usually that includes, why are you proposing it? So what is the condition that you're recommending ECT for treatment of? What is ECT? So what is the condition? What is the treatment that you're actually proposing? What are the risks and the benefits associated with the treatment? And then what we often don't do so well is, what would be the alternatives to ECT? So if they decide that they don't want to have ECT, what would be the alternative choices? And then finally, once you've gone through that, you need to give the patient or the decision maker an opportunity to ask some information back to you, right? To ask some questions. And it is important to document that part of the discussion. You don't need to say too much, but you do need to say that that you asked if there were questions and they didn't have any questions, something like that. You can really help this process along by utilizing some of the DVD resources or the online resources that I think Dr. Chan spoke about earlier. So the Connects website has an online version of the patient and family DVD on it. Or if your site has a written information package about it, that can be really be helpful and speed the process along of getting people to ask questions. So you can give it to patient or family, and then your next visit with them, you can just ask them if they have any questions around it. So when we talk about valid consent, it really includes all of those 6 points, okay? Not just the form. So I wanted to spend a couple of minutes on this idea of just going a little bit more into this idea of capacity or incapacity. And really, when they talk about that, they talk about sort of 3 domains, and I think I only wrote down 2. in here. But really, the first is, does the person understand the information that you're giving them? Okay. The second is, do they actually appreciate it? So do they understand that this information has anything to do with them, right? So the classic example is someone who can tell you everything about depression but doesn't think they are, even though they're not eating, drinking, and are suicidal. Okay. The third element that I didn't put in here is actually the ability to come to a, not only does someone need to understand and appreciate, but they need to be able to come to a decision about it and express a wish. Okay? And those would be the three elements of what we'd call capacity. We talk about this idea of decisional capacity. And when you're trying to assess that with a patient who you're seeing, really you can get an idea of it by presenting information to them and then asking them what they understand or to give you their feedback to it. If you're part of an outpatient ECT service and you're sort of picking somebody up midstream who's being referred to you specifically, you might be able to shortcut it a little bit by kind of saying, Mr. Smith, I understand you're here for ECT. Tell me what you know about the procedure already, because they actually may have had a lot of work done before they even get to you, right? And it will give you an idea of where to start some of your discussions with them. The next part is a little bit of an excerpt from that American Psychiatric Association textbook that everyone's been talking about, that 2001 book. And again, it goes back to saying that capacity is always assumed to be there. If you say nothing, the person in front of you is capable of signing or of providing their own consent. And that in order to say that somebody is not capable, you need to actually have fairly compelling evidence for that. Okay? The presence of psychosis in and of itself isn't enough to say that someone's incapable. The presence of what they call irrational thought processes by itself isn't enough to say that someone's incapable. And involuntary hospitalization, all of those things by themselves won't mean that someone is necessarily incapable. They still may have capacity to make a decision around ECT. So I've put up just some ideas about some of the conditions that can sometimes interfere with capacity. So although psychosis by itself isn't necessarily enough, it really depends on what the psychotic content might be, right? So if someone has delusions or other thought content that center around ECT or the alternatives to ECT or the risks associated with the procedure, that might mean that they actually don't really truly understand the risks and the benefits of it, right? So a couple of years ago, I had someone who was very ill and was very convinced that that people were going to be coming to the hospital to take her to another place in the hospital where she was going to be tortured and murdered. Okay, that was part of her delusional system. She, of course, didn't want ECT because we didn't do it on the ward. We had to go out of the door, right? So it made very much sense in her own world that, of course, she would never consent to a procedure. She wanted medications, right? So that would be an example where the delusions are really interfering with the idea of risk or benefit. People who have decreased attentional capacity to the extent that they actually can't register some of the information about the risks and the benefits, that might make you think that they're incapable. People who have really impaired decision-making ability, so in very, very profound depressions, that might influence it. And of course, someone who really doesn't have any insight into the nature of their illness, that would influence it on the basis of the appreciation component. Okay. I've put in there for completion that idea of fluctuating insight. In my practice, I will often say that those people who have really fluctuating insight, I will often say that they're not capable. Okay, simply because in the morning they want to have the treatment, or in the morning they understand that they have depression and they want to get better, but by noon they don't have depression, and it makes it really difficult to implement any treatment plan if it's fluctuating that much. Okay. So we've talked a little bit about what the components of consent are and how do you figure out if someone's capable or not. So in this idea of capacity, then you really want to look at who do you approach to get consent. So who are you actually trying to get consent from? It's obviously one choice is the patient, but if it's not the patient, where do you go? And this is really, really driven just by legislation in British Columbia. So if someone is voluntary, so if you're seeing them in the community for a typical course of outpatient ECT, or they're admitted into the hospital on a voluntary basis, it's the Healthcare Consent and Facilities Admission Act, and that rules all of your decisions around how you will approach this patient. If you're looking at delivering ECT to somebody who is under the Mental Health Act legislation, so they're involuntary, so it could be somebody in the community under extended leave, or it could be somebody admitted into the hospital on an involuntary basis, then it's the Mental Health Act. Okay. So going to the voluntary side, people who are voluntary, in the law, ECT is considered to be what they call a major healthcare decision under the Healthcare Consent and Facilities Act. So that act has what they call minor healthcare, major healthcare, and emergency healthcare, and they have all sorts of rules around how you address all of those. So ECT is major healthcare under the Healthcare Consent and Facilities Act. And just for interest, the other things that are major healthcare are radiation, chemotherapy, dialysis, ECT, and laser surgery. Okay. Under the Healthcare Consent and Facilities Act, if someone is capable, so you've done your assessment, you feel that they're capable of providing informed consent, then it's really, really, really simple. You get your consent from the patient, right? If somebody is voluntary, but you feel that they are incapable for whatever reason, right? It could be a developmental delay, it might be comorbid dementia, could be a whole bunch of reasons, right? If they're incapable, the law tells us that we need to get a second opinion for those people. And then, because they're incapable, we have to identify a substitute decision maker for them, and it's that substitute who does the rest of the consent process on the patient's behalf. The necessity for a second opinion, this is where it came from, so I just literally cut and paste this out of the Act, right? So the temporary substitute decision maker, or TSDM, can't consent to ECT unless it's recommended in writing by the treating doctor and at least one other practitioner who has examined the patient for that purpose. Okay. Sorry. So the nice thing about the Healthcare Consent and Facilities Act is it does tell you an order of who can be the substitute. Okay. So if someone is incapable, there's sort of a hierarchy, a list that you can go to. And so often, well, not often, sometimes, rarely, people have had this looked at before, and there might be somebody already designated as a substitute. So those would be people who already have a comity of person that's been designated by the court. Okay, they actually have the number one priority as substitute decision maker for ECT. If there's no comity of person designated by the court, sometimes people have already in advance designated a representative. It would be a Rep 9 agreement, okay, where they've identified the person who they would want to consent on their behalf. And if either of those two exist, that's who you have all of your discussions about the risks and the benefits and the alternatives and so forth. Okay. Not very many people have a committee or a rep. So usually we end up defaulting to the listing within the Healthcare Consent and Facilities Act to look for a substitute decision maker. And literally, it's written out in the Act kind of like this. You can actually Google it, if you, like I often need to Google it, right? And they list out the hierarchy of who you would approach. Okay, spouse, child, parent, all the way down the list to the Office of the Public Guardian Trustee. Okay, and that would be the person who you'd have all of your discussions around consent with. They do put some qualifications on that. So even if you might qualify on the basis of the list, they have some exclusions, right? So you have to be 19 years or older. Okay, I've had a couple of patients with very early onset dementias. So their children are 17, 18. That means that I can't go to them as a TSDM. They have to have had some contact with the patient within a 12-month period. They also need to not be in any dispute with the patient. So long-lost feuding relatives wouldn't qualify. They themselves have to have capacity. Okay, so again, in my line of work with seniors, sometimes the spouse, who would be the top person on the list, sometimes the spouse themselves may have significant cognitive impairment and may not actually have capacity themselves. And the substitute decision maker needs to consult with the patient to the extent that it's possible, and they need to abide by the patient's pre-expressed wishes, not by their own, but by the patient's pre-expressed wishes. So again, just to review, if you're voluntary and you're capable, easy peasy, all the discussions happen with the patient. If you're voluntary but not capable, the law says we have to get a second opinion. The law says we need to look for a substitute decision maker, and it's that substitute decision maker who you have all of the discussions with. Okay. I'm going to shift tracks now to the Mental Health Act and people who are either on extended leave or admitted on an involuntary basis. So if you're involuntary and you're capable, again, really, really, really simple, right? You talk to the patient and you'd have all of the discussions with the patient. When it comes to the actual logistics of what you sign, there's not really a comment in the law about what exactly you sign, okay, for that final stage of signing a consent form. The process up until then, so all of the discussions about the risks and the benefits is exactly the same, but for that final component of signing a form, you have a choice under the law. You can either use the Form 5 of the Mental Health Act, which is that consent for treatment form that has those two arms, right? We usually use the right arm for people who are not felt to be capable, but there's an arm on the left for people who may be capable. So one choice would be to use a Form 5 and have the treatment being proposed be ECT on that. Or you could just use the surgical consent form for your facility. So for us at VGH, we don't deal with Form 5s, we do it through the surgical consent form, but that's really a site-specific decision and doesn't have too much to do with the law. If you're involuntary but incapable, it's recommended that you get a second opinion, but it's not necessary. There's nothing in the Mental Health Act legislation that says that you need one. Okay. And under the Mental Health Act, if someone is incapable, it's the director or the designate of the director who then is the person who would officially put their blessing on the consent. Okay. Again, there's nothing in the law that says whether it's the Form 5 that is actually the form or whether it's a surgical consent form. The director can sign in either one of those places, but it's the director's signature for that very last step. I always put an asterisk here just to remind everybody that in the Mental Health Act, nowhere does it say that family need to give consent in there, okay? It's not required by the official letter of the law. So just a couple more comments about this involuntary incapable arm. I sometimes shorten that to talk about what we call deemed consent. That would be what it means, where the director is giving consent on behalf of somebody who's involuntary and incapable. As I mentioned, that family consent isn't necessary under the law, but it is very strongly recommended to have assent from a family member. Okay. Sometimes there are 5 million different family members, and they internally may be disagreeing amongst each other, but in practice we try to get agreement from at least one person within the family. And it would be very, very rare for us to go ahead with a course of ECT if there was absolutely no one in the family giving any agreement. Okay. Often, if we're in that position, we'll really search hard for other alternatives to ECT. Having said that, I've been in practice for 14 years, and I've had 2 times where I've gone ahead when I had complete and utter resistance from family members. And those are those incredibly high-risk cases, right? Someone's acutely suicidal, they're making attempts on the ward, they're absolutely not eating and drinking, and they're having cardiac compromise because of that, right? So sometimes you may need to make a decision to go ahead. When I have been in that position, I basically tell the family to apply for a review panel, okay? Because if they are successful on a review panel, then it bumps them out of that involuntary arm, puts them into the voluntary category, right? Where then the patient will still be incapable in either case, but it would mean that they would be voluntary and incapable, in which case it would be the family members who would be the substitute decision maker, right? So for me, that's my solution. Yes? Yeah, I would have already had, so for my practice, I do get second opinions anyway, even though it's not necessary. So I would have had a second opinion, would have gone through it with them. I would have told the family to get a review panel. Again, in those 2 situations that I've had, because it's been so urgent, I have started the course of ECT. So they have had, you have to get a review panel within 2 weeks, right? So usually people have had 2 or 3, sometimes 4 treatments before the review panel would be held. In both of my personal cases, the family have seen improvements within that time, and they've actually canceled their application for the review panel. But, it wouldn't have been a problem if the review panel felt that the person didn't meet the mandate of certification, then I would have stopped anyway. Yes. Yes. I would do the same thing, depending on the urgency of the situation, right? So if it is, if ECT were a nice to have versus an urgent situation, I might not actually even pursue the idea of ECT if the patient were really against it. If I had other viable options for medications, that would be a bit of a negotiation, right? But if it were really urgent, I would still start the course of ECT. The patient would have their review panel within that 2-week period, and I would just follow the results of the review panel. Yeah.
The function of the review panel is to decide whether the patient is certifiable or not.
Yes.
So we're talking here about a patient at a high risk who is unable to give consent, and then we ask the review panel to decide whether we should release them from the Mental Health Act or not. So it sounds contradictory to me.
No, it is a little bit, right? You're right. The review panel, their whole purpose is to decide whether they're voluntary or involuntary, right? No, and I'm not asking them to decide the type of treatment, but it does make a difference as to who the substitute decision maker is. Okay? So it doesn't change the patient's capacity. The person would still be considered to be incapable, whether they're involuntary or voluntary. But if there is absolutely nobody on board within the family, and if the review panel says that an involuntary hospitalization isn't supported, then I, as a treating physician, needs to abide by that, and I need to then allow the substitute decision maker under the healthcare consent to make the have the treatment decision in there. Yes. Yes. Yep. Absolutely. Yep. Yeah. Yeah, and again, like I said, I've only gone to this route twice, right? These were people who were very, very ill. I was fairly confident that if the family had chosen to go to a review panel, that they would not have been successful on it, because you're quite careful, right? If you're pursuing this option, but it does at least give the family members who might be really opposed to the treatment, it does at least give them a little bit of a feeling of control in that procedure. Okay.
Heather?
Oh, I'll go here and then here.
I just want to ask about, I just recently actually had a patient myself, a young woman with depression, multiple suicidal attempts, multiple hospitalizations, wouldn't take any oral medications, we did daily dispensed everything. And then we were thinking about ECT. Dr. Kang actually did the second opinion on her, and we felt that she will benefit from ECT because she did that in the past. But she refused, right? She wouldn't consent. And then physically it was not possible to do the ECT on her, right? And the anesthesiology people refused to do it. So what would you do in a situation like that? We didn't do the ECT on her, but...
Well, I mean, I think that whole discussion about the consent process is based on the risks and the benefits, right? So if the risk is so high risk that anesthesia is saying no?
No, they're saying we are not going to physically restrain her. We don't want her to be restrained to do the ECT, right? Because she wouldn't do it, she wouldn't go for the ECT herself. She's a young woman. She's 24, 25 years old. So.
And how ill was she right at the time?
Pardon me?
How ill was she right at the time of her refusal?
She was quite depressed and refused all sorts of treatment. She just would not take medication, wouldn't do anything. So, and she has two really young children, 1-year-old and 3-year-old, and she has postpartum depression. So.
Yeah, I mean, I think at the end of the day, that sounds like a really challenging situation. At the end of the day, you really need to, probably the crux of the issue will be whether or not she's capable. Whether or not you feel that she's capable of making an informed choice.
Not, because she had no insight. Right?
Yeah. So then I'll put you on the spot, Dr. Kang. But that would be also one of the that would be also one of the comments of the person who's doing the second opinion, right? That's part of why you do get a second opinion as well, right? In terms of seeing whether or not the person has capacity. Again, without knowing too much information, I would probably suggest, maybe a little bit inflammatorily so, I'd probably suggest that that it may not be the role of anesthesia to make a decision about the manner in which someone arrives into the suite, like in terms of the idea of restraint or not. Okay.
Let's see, Heather, I'm sorry, I'm feeling compelled to talk about this. Then, if you heard Peter's talk, number one barrier is anesthesia. So that remains a problem. Unless you have a very specific ECT setup, where they're used to all these little subtleties of problems, or logistical problems, you can't get these ECT. She was very quick to tertiary turned her down. We had no more ability to give ECT than you guys can. So where is it going to happen? Nowhere. So she's occupying acute care bed for no reason.
She's still on the unit.
Okay. Yeah. Yeah, I mean, I can hear this. I can hear the frustration, and I do think that's really challenging, but I would sort of suggest that that probably isn't, that the role of anesthesia is, probably wouldn't include the scope of restraint versus not.
That's a specific team where mental health act, that is sort of this team who works with these things. You actually understand what psychiatric needs
Yep.
are.
Yep.
They would understand that they need to cooperate with this. When we were in that situation, we would do that and sitting in a chair. Once they're sleeping, then they lift it up.
Yes. Yep. Yeah, absolutely. Yeah, so, you know, I think this is going to be a much larger discussion, and I know I don't have time for this, but I certainly understand what you're saying, and that I think any time ECT is not being given frequently in a location, and when it's a relatively new procedure for the entire team, there are going to be a number of biases that do need to be overcome, and it often takes a really long time to get the global staff on board with it, right? I know my experience at VGH, because I trained there as a resident and then beyond, right, was that when I very first started, there were certain staff who refused to work on the ECT slate, right? Because there were quite strong personal biases, and has taken a lot of in-servicing and a lot of education to try to have the procedure be looked upon more favorably. But that's, I think, much beyond the scope that I can cover today. Okay. Yes. Sorry. Yep. Yes. Yep. Yes. Yeah, and I think that's going to be I think that's a great point. There certainly have been some cases where I have called the CMPA and run a specific situation by them. I'm very careful with my documentation, and that's part of why I did spend that time up front about the information that you give to people, about the alternatives and so forth, right? The risks and the benefits. You know, you do really want to have your rationale for pursuing ECT as an option, especially in the controversial cases, be very, very, very clear, right? That's why I'm saying that, again, if I have somebody for whom ECT would be a good option, you know, they're ill, they're in hospital, they're under the Mental Health Act, ECT would be a good option, but there may not be that same real urgency right at that moment. That if I have no family member on board, for me, I will often not pursue ECT in that case. I would go to another medication trial. Again, those are the kinds of clinical decisions that you're making all of the time. Okay. Oh, yes, one more question. Mm. Great. Yeah. Yeah, great question. So the short answer is in BC, powers of attorney only apply to financial issues. Okay. it's particularly challenging when family members and family have lived in other provinces. So in some of the other provinces, they might have power of attorneys that do look after personal care issues, but they don't have validity within BC at the moment. Okay, so I'm going to move on. I'm going to skip over, actually, I think I have already skipped over the part about children. Sorry, I put in one page about the legislations that apply. So that's in there for completeness, but I will skip over that a little bit. I am going to speak a little bit about forensics patients, just to highlight some of these concerns that can come up when people are receiving their treatment at another hospital from where they're admitted. Because I understand from speaking with Dr. Wilkins-Ho that that's a big issue here in the Fraser. For me at VGH, we see this mostly with our forensics patients because we do the ECT for people who are admitted at FPI. So their primary hospital is FPI. They're coming to a different facility for ECT. So in this case, those patients are often having their ECT being done under the Mental Health Act. And we made an internal decision, like a site-specific decision, about who would sign the forms and which forms would they sign. So in that case, the decision was that it was the FPI director who would sign the Form 5 of the Mental Health Act that says ECT. And then we wanted at VGH to have something with our VGH director on it, just recognizing the fact that the procedure was being done in a different location. So our director actually signs the surgical consent form for VGH. That's not really driven by law. Remember I said that the law doesn't really say exactly which form needs to be signed, but that was sort of the solution that we had. And for forensics patients, if the ECT is being done under the Forensics Commission Review Board Act, we had a similar solution. So the FPI director was signing the treatment order with all of the specific dates. And in this case, it's not under the Mental Health Act, so there was no Form 5. It's a specific treatment order, court-ordered treatment order. And then our VGH surgical consent was signed by our director. So that was the solution that we had. But again, that's not particularly legislatively driven. Okay. The last thing I'm going to say, yes. Yes. Okay. Oh, I did not know that. Thank you for that completion. I'll amend the slides. That's good to know. Thanks. Okay. Oh, yes.
I had a question actually. I mean, in this situation, would it be appropriate actually to use the Form 20? Because, say, for example, a patient from Forensic Psychiatric Institute having some major medical problems, receiving the ECT at Forensic Psychiatric Institute, has to come to VGH temporarily for 2 or 3 weeks, has to pursue the ECT. So in that situation, can you utilize the Form 20 from the Forensic Psychiatric Institute as if the patient has been discharged into the community under the care of the psychiatrist at VGH, and then once the treatment is over, patient will be recalled back to the Forensic Psychiatric Institute?
Interesting question. Possibly. Okay, I'm sort of hedging my bets a little bit. Possibly. I think logistically with the people who we have, they don't stay at VGH, so they're just transferred in by ambulance for a morning, right? So they're actually not discharged from their originating hospital. Like they're not discharged from FPI, in which case a Form 20 probably wouldn't be appropriate. There may be a situation, although I can't really think that I've had the practical experience of one, there may be a situation where someone is discharged but still is connected with the forensic system, where it may be appropriate to be doing outpatient ECT in a location, in which case it may be appropriate to use a Form 20 in those circumstances. I haven't run into that though. Mm-hmm. Okay. 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 Thank you. Okay. So the last area I just want to talk about is a little bit about consent and how long it's valid for. And again, this is not driven by the law, but is actually driven by our provincial guidelines. Okay, those 2002 provincial guidelines. And in there, it is recommended that after 15 treatments, if somebody hasn't shown a significant response within an index course, that it's recommended that a second opinion be obtained as to the advisability of whether to continue or not. And so that's sort of what would be defined as an acute course within the guidelines. Okay. Of course, if the patient themselves is capable, they're capable of granting consent and they're capable of refusing it, right? So someone could make a decision after 2 treatments that they don't want to continue the course of ECT, and if you feel that they're capable at that time, you need to abide by that. And that's, for me, sometimes the most frustrating thing is people who stop their course of ECT early, but I need to abide by their consent if they're capable. And then for people undergoing maintenance ECT, the provincial guidelines recommend that renewed consent happen every 6 months or every 15 treatments, whichever one comes first in there. So I'm going to stop talking about consent and I'm going to skip about 5 or 6 slides for a bit because we've had quite a big discussion and we're completely into lunch hour. You're more than welcome to read the materials, the extra bit of materials. I just put some information about some tips for how to chart things and what kinds of things to say, and those are really based on the provincial guidelines and the risks outlined within the provincial guidelines. I'm going to skip that for the interest of time. But I'm happy to answer questions over lunch hour if people have any questions about that. Okay, I apologize about lunch. I'm going to totally switch topics a little bit to concurrent medications, and I know that there were lots of questions earlier. Again, because I know that we're so short of time, I'm going to maybe ask to answer some of those questions over the lunch hour, but just to really try to give you the approach to take, okay? I think this is really important because it really is essential that we review the medications before starting somebody on a course of ECT. In terms of some general principles, for most people, if they're taking medications, most of the medications that they take are continued through the duration of the course of ECT. For most of them, we don't really adjust that much. Having said that, we often need to adjust the dose or the timing of the medications. And we need to be conscious that we may need to specify that within the pre-ECT orders for people. Because ECT happens over a period of time and medications are usually there for a good purpose, if you know in advance that someone's going for a course of ECT, and if you know in advance that you probably don't want something around during a course of ECT, it's optimal to try to discontinue medications gradually leading up to a course of ECT. That's not always possible, but it's optimal. In general, if a medication has a protective effect for the physiological changes that Dr. Shabbatz was talking about, then it would be important to give those medications prior to each individual treatment with SIPs, right? And in general, if medications interfere with the ability to deliver ECT, or if they have other adverse effects, then you either want to reduce them during the course of ECT or hold them for the morning of the treatment. Okay, those are really some pretty general principles. The approach that I wanted to talk about is actually just these 4 points, okay? So when you think about medications, there really are going to be only 4 reasons that you want them around. So the first is to keep someone's medical status optimized. And that really has to do with that pre-ECT, the anesthetic consultation that was spoken about with Dr. Shabbat's, right? You want someone to have the most robust medical status going in to the course of ECT. The second goal of the review of medications is that you want to minimize any adverse effects coming from ECT, okay? So when we talk about the risks, and this is part of what I skipped out, when we talk about the risks of ECT, we usually talk about the most common and the most serious. And when we think about the most serious, the 2 that are most often talked about are the mortality risk, which we've spoken of already, and then the cognitive risks, okay? So really number 2 gets to those things that are minimizing ECT-related adverse effects, okay? The third reason to look at your medications is that you want to maximize your chance of actually being able to induce a seizure when you're in the ECT suite, right? There's no point in getting somebody there doing all of the work, stimulating and not actually having an adequate seizure response. And then the 4th reason to have a medication around is to try to actually maximize the overall response rate coming from the ECT. So is there a reason to have a medication on board that would mean that more people would get better, or people might get better faster? Okay? And those are really the only reasons why you want to be thinking about medications. So in terms of the medical status, again, typically, if you need them for your health, you need them for your health. You would continue on them throughout the course of the ECT treatment. If they are protective for the physiologic changes of ECT, you give them with SIPs on the morning of the treatment, on the day of the treatment. Otherwise, if they don't need them for the actual physiologic changes within the ECT treatment, then you would withhold them and give it to them after they emerge from their anesthetic, once they wake up. But you continue them throughout the course of the ECT treatment. And clearly, if there's a risk of an adverse interaction between the medication for their physical health and the ECT treatment, then those would be the ones that you would hold until after the treatment is completed on that day. So I'm not at all being inclusive, but these are just some examples of medications that you might give with SIPs on the morning of the treatment. Okay? These mostly make a lot of sense. So antihypertensives, reflux agents, bronchodilators, those sorts of things. And some of examples of medications that you might choose to hold until after each individual treatment might be something like a diuretic, right? People get incontinent and they feel really terrible about that. It doesn't make them feel good. And there's a small risk of bladder rupture with it. Insulin and hypoglycemic agents we were talking about, the person is NPO anyway, and they have increased glucose needs during the ECT treatment, so you don't want to contribute to that by giving them insulin or an oral hypoglycemic, fasting them, and then sending them for ECT. Theophylline, it's not used that often now, but there are some case reports around status seizures, even within the therapeutic range. So you might choose to hold that. And then I know there was a whole discussion about anticonvulsants. And since I've had some personal experience, as Dr. Chan was mentioning, with people with seizures disorders, That's a huge discussion. Again, I'm happy to have that on the break if people have more questions about that. I think that for the purpose of this talk, though, really we're all psychiatrists and, in the mental health field. So if you're in doubt, ask for a consultation, ask for guidance around what to do with medications. Okay. For psychotropic medications, we're really looking at those final 3 issues. Okay. So in terms of minimizing ECT-related adverse effects, I found this picture online. It's one of the, very skewed things. Still damaging brains and erasing memories. So really, you want to do no harm. If possible, do no harm, right? So it's favorable to discontinue as many medications as you can during a course of ECT from a psychotropic perspective, mostly to reduce the risk of the cognitive side effects, right? Most of those for each individual treatment day, you would include those in the NPO order if you're continuing something through the course. But if you have a whole bunch of adjunctive medications, it's optimal to try to run your course of ECT as cleanly as possible with as few ongoing psychotropic medications as possible. Some specific medications, lithium, there's quite a good, robust body of literature about increased risk of postictal delirium with lithium around, and some evidence around prolonged seizures as well. So the recommendations with lithium is, if it's possible, you do not want to have somebody on lithium during the index course of ECT. If that is not possible because of their clinical condition, so if someone is very manic, for example, right, you can start it or you can continue it, but you would want to run your blood levels a little bit lower than what you would be eventually aiming for. So again, for an adult, rather than running at blood levels of 1, you might be running at blood levels of 0.4, 0.5 during the course, and then only after they finish the acute course would you then further increase the dose of lithium. Okay. Also, the other condition that this sometimes comes up on is if people are now on maintenance ECT, and lithium is part of their maintenance medications. And so, of course, you don't really want to stop that. It doesn't make sense, right? But again, you want to try to reduce their level at the time of the ECT, so you might hold their lithium level the night before, just to have a transient reduction in their blood level at the time that you're delivering the ECT treatment. Okay?
Excuse me, so they are skipping 1 dose of the lithium?
Pardon me?
On the day of the maintenance ECT, they just skipping that dose of the lithium.
And the night before, if they have a night before dose as well. Yeah.
Okay.
Yeah, you're just trying to get a transient reduction in the blood levels before. Yeah. So again, if we think of trying to reduce cognitive side effects, we know that our psychotropic medications have a whole host of anticholinergic side effects, right? So that puts people at increased risk for postictal delirium and cognitive side effects with the ECT. You're just exposing them to a higher risk. So again, you might need to have them around through the course, although if you can, you want to try and not have them around. But if you do need them, if you really, really need them, you wouldn't give them on the morning of the treatment, right? You would hold it until after the treatment. Give it after. The next goal of a medication is trying to get an EEG strip that looks like this, right? That you actually get them into the suite and they have a good treatment response. So a lot of this makes sense, right? If someone is on an anticonvulsant for a psychiatric reason, it's not that it's not safe, but it increases the seizure threshold, so you have a lower likelihood of being able to actually induce a good seizure, right? So if possible, you want it not to be there. If it does need to be there, you would want to maybe hold the night before, and you would certainly want to hold the morning of the treatment and not give it until afterwards. Same thing with benzodiazepines, also increases the seizure threshold, right? Again, if you can possibly not have any of them around, great. If you do need to have them around, you want to have a short half-life benzo, shorter half-life benzo. And if even with all of that, it's absolutely necessary that they be on it and you're in the ECT suite and you can't deliver an adequate seizure, your last resort option is to look at using Flumazenil, right? So it's a benzo antagonist. So after someone has had their been induced, they get Flumazenil through the IV. It antagonizes the benzodiazepine. You give the stimulus. They have the seizure immediately following. They get IV midazolam immediately because you can go into bad withdrawal. And then they emerge out of the anesthetic. Okay? So there are some options that you can use. Generally, antipsychotics reduce the seizure threshold, so you might think that it's not a bad thing to have them around on the morning of the treatment, but many of them have anticholinergic effects, so you're balancing that. Generally, again, I advocate for a clean course of ECT, so there's not necessarily going to be a necessity to have an antipsychotic given on the morning of the treatment. You would still probably hold it and give it to them following the treatment. The exception would be if you have that really combative patient, right, and you needed some way to transport somebody down in restraint. You might choose to use an antipsychotic because at least you know that it's not going to interfere with getting an effective treatment response. The very last point about psychotropic medications is this idea of, does it confer any benefit by starting, I'm going to say for antidepressants, by starting an antidepressant while you're in the course of ECT? There's surprisingly not a whole lot of research around this. There's a little bit. But the whole idea of this has been the fact that all of our antidepressants take 4 to 6 weeks to work. Right? And so if you do your ECT with no antidepressant around and you put the antidepressant in right at the end, there's that idea that you have a risk period, right, where someone may not have a lot of protection. I'm going to skip this one. So, there are two aspects of the arm. One is there any benefit? The second is there any risk? So let's talk about the safety risk first. Generally, the SSRIs now are thought to be relatively safe to use during a course of ECT. So there aren't a lot of safety considerations around that, okay? Nortriptyline, there is a lot of actually really good evidence, and I'll present one study. There's a lot of very good evidence that actually the clinical effectiveness of ECT is enhanced when nortriptyline is on board during the course, so that might make sense to be using. Bupropion has effects on seizure threshold, right? The concern with that all along has been whether or not you put somebody at risk for status or uncontrolled seizures. There are some case reports saying that it has been safely done, okay? Having said that, if you don't need it, don't have it around. Right? So again, if you are, again, just advocating for that idea of trying to not have risky things around during the course, right? Very occasionally we will use it if we have been giving a course of ECT and someone's at maximal stimulus and we can't get any response. We'll sometimes consciously put it in. But most of the times we are advocating for it to be stopped during an acute course. And MAOIs are thought to be safe, except for that anesthesia definitely needs to know because their management will change quite a lot if an MAOI is on board. In terms of the overall antidepressant effects, the take-home messages are, I might skip through the literature, but the take-home messages are that it's unclear if adding in an antidepressant gets people better and gets better faster. Okay. The there are a couple of gold standard articles. So the Sackheim article is one. And I'm going to skip through their research design a little bit to their results. Their results are that the combination of nortriptyline and ECT during an index course did get more people better than ECT with placebo. Okay. They also had an arm, though, that they looked at combining ECT with venlafaxine, and that's number 3 that's asterisks on there. The combination of ECT plus venlafaxine in the acute period, there was no incremental benefit on response rates for an acute course. So some antidepressants in the study worked, some didn't. Okay. The other thing that was a little bit interesting was the number 4 point, was that actually that combination of ECT and venlafaxine had some worsening of cognitive scores, which is a little bit of a surprising outcome as well. Okay. So an antidepressant may or may not, depending which one you use, actually get more people better faster. The other question is, if you start an antidepressant early, does it actually prevent relapse, right? So there's a 2010 article by Yieltz, and he was looking at sertraline, and his whole thing was whether or not if you start sertraline in the middle of your course of ECT, do you have fewer relapses than if you started at the conclusion of an index course? And he followed them up for 20 weeks after. And the addition of sertraline in the middle of the course, the relapse rates were significantly less. Okay, so addition of an antidepressant in the middle of your course of ECT is probably beneficial in preventing relapse and having better long-term results. With sertraline. But then there was another study with venlafaxine and nortriptyline, where, again, they looked at people who had been on medications all the way through the entire course or added in or at the end. And the nortriptyline and the venlafaxine didn't seem to make a difference for relapse in that particular instance. So it's still a little bit equivocal. We're getting some more information, but it's not fully clear. So again, when you're thinking about medications, these are your only 4 things that you're wanting to have them around for. Keeping people healthy.
ICU, critical care tower, room 7, code blue, ICU, critical care tower, room 7, code blue, ICU, critical care tower, room 7.
Yeah, so again, just going back to the approach, really, you're optimizing their medical status. You're trying to minimize ECT-related adverse events, which are usually the cognitive ones. You're trying to maximize your chance of getting a good treatment response in the suite. And finally, you're trying to see whether or not you can enhance someone's overall clinical response. For the very last couple minutes, I'm going to talk about geriatrics. And again, I apologize that it's quick. Geriatric depression. We do know that there's an increased effectiveness of ECT in this population. Okay, particularly in mood disorders with psychosis. Probably the best article is the Navarro article in 2008, and they actually had an 86.8% remittance rate. So not response rate, but full remission, which is pretty incredible if you think about it. Just to go back to that study, just to note that they did the study with ECT in combination with nortriptyline, which we know also helped to boost that up. Right? We also know that older age predicts a faster response to ECT. So not only do more people get better, but they get better faster than younger aged people. So there's I put in here for your benefit just a retrospective trial, but it was a large one. It was 150 people. And there are many other studies that show this as well. We know that that idea of adding in medications earlier in the course, and looking at whether adding medications in early in the course, whether it prevents relapse. There was a negative, what I call a negative study with people of all age, but when they actually separated out by age groups, adding in medications early in the course, this is the Effexor and the Nortriptyline in combo with lithium, that the relapse risk was much, much less and significantly less in the old age population. And actually, when they looked at people who completed 6 months with no relapse, those people were more than 10 years older on average than people who relapsed. Okay. We also know in geriatric depression that if you're looking at continuation ECT in combination with medications, that there's a much lower relapse rate than if you look at just maintaining people on medications alone. Okay, so finishing an acute course and maintaining on medications alone. And again, this Navarro study is where the citation is from. So the survival time was on average 23 months to relapse if they were in combination of continuation ECT plus nortriptyline versus 16 months if it was nortriptyline alone. They did use risperidone for a short period of time in that population too. So there's some really great things in terms of using ECT in geriatric depression. And we don't totally understand why, I've put up my speculations about some of it. But the take-home message is, in your geriatric folk, really think of ECT early for geriatric depression. It works really well. For 2 seconds, I'm going to talk about Parkinson's disease, because often our people might have comorbid Parkinson's as well, and it's a secondary indication for ECT. There's a body of evidence that it does work. They tend to be small studies, and they tend to be either case studies or case series, sometimes in Parkinson's disease alone, and sometimes in comorbid depression with Parkinson's disease. Okay. It definitely works. There's a suggestion that right unilateral placements might be preferable, but there are also successful reports of people having bilateral treatments, either bitemporal or bifrontal, and getting good response. When you look at the case series, the main concern about bilateral treatments is really in terms of the cognitive side effects. Go ahead. Yeah.
Thoughts about Parkinson's and ECT. Are we using it that much? What about the neurologist? Are they on board?
The neurologist.
Are we treating one more thing? Are we treating the depression or are we treating the Parkinson's?
Yeah, great question. So in terms of the case series and the case studies within the literature, there are both. So there are both case series with people with Parkinson's only, with no other psychiatric illness, where there is a benefit, primarily in the on-off phenomenon, but also in some other areas as well, independent of other psychiatric issues. I like your question about if the neurologists are on board. My personal experience has been that they're usually not all that interested to use it as a primary indication, but they will be supportive. But if you can make an argument with them, they usually will come around. And usually, for me, in those cases, it's people who have another indication, but also have Parkinson's disease, where it's an added benefit. But they haven't been particularly I haven't had any referrals, I don't think, of people for primary Parkinson's disease. The neurologists aren't all that interested. Okay. Okay. Yeah. Okay. Yeah, and actually in terms of that, thank you, Nirmal, for reminding me, if you are doing a course of ECT in someone with Parkinson's disease, you probably do want to look at your dosing of Sinemet during the course, because they probably won't need as much, right, throughout the course, and you can run into some cognitive issues if you have higher doses than are needed during the acute course. So you actually probably, if you are doing it, in conjunction with neurology, you might actually want to reduce their general dose of Sinemet through the course. Finally, I want to look at dementia-related illness. So Charlton Heston and Ronald Reagan together. The take-home message is that ECT is effective in the treatment of depression in those who have dementia as well. Okay? There are some case studies that show increased risk of cognitive decline, particularly in people who have vascular-mediated dementias, which goes back to Dr. Shabbat's comments about the physiology. Prospective studies show that there's an increased risk for post-ictal confusion. Prospective studies show that the pre-ECT level of cognition is the best predictor for reduction in Folsteins at 6 weeks after treatment. So, but then when they followed people out to 6 months, actually their Folstein scores were on average higher, 1 point higher. So it wasn't a sustained response. And on here is a really good review article for the literature in dementia-related conditions. Just in terms of geriatrics, there are a couple of practical points. One is that seizure threshold goes up with age, so it actually just gets harder to do any kind of ECT, particularly those that have to be a high amount above seizure threshold. We talked about the ECT-related cognitive effects. There's a much higher risk of medical comorbidity, and so much higher anesthetic risk on average. Very rare for me to see an ASA1 ever written on any of my patients. Because of that, I use consultation a lot, right, to get people stable. Again, it's okay to use it if someone has comorbid dementia. There is currently not an indication to use ECT specifically for BPSD, although it is used off-label for people who have run through absolutely every other option in treatment for BPSD and are still having significant distress, but it would be not a primary or a secondary indication. It would be quite a bit off-label. And in terms of just some practical considerations, generally we'd be looking at booking somebody twice a week rather than 3 times a week, mostly because of the cognitive risks. Again, because of cognitive risks, we're sometimes looking at our electrode placements and making decisions about that. It would be a little bit more rare for us to go to bitemporal treatments. The seizure threshold issue is a difficulty for right unilateral treatment where you have to be 5 to 6 times above threshold. Sometimes we actually just can't do it because their seizure thresholds are so high. And you want to just keep a really close eye in terms of their cognition throughout the course.
I'm sorry, just very short question. Is there any cut-off cognitive decline when you say we cannot continue ECT? Let's say that there would be drop of the mini-mental or MoCA on some amount of points, or how do you judge it? Decline, how?
Great question. For me, I don't have a hard cutoff, but it's discussions that I'm having with family all the way through. And I will start to adjust the frequency and the electrode placements through. I might hold the ECT for a period of time, see if the confusion, if the memory returns, and then maybe go back using a right unilateral or bifrontal treatment. I'm more trying to manage it without having a hard cutoff. And it really depends on the person's clinical condition, right? So if someone is 70% better, I might simply stop the course of ECT and finish off with medications. But if they're really severely ill, I might need to keep pushing on. So for me, I don't have a hard cutoff. I'm going to stop. Sorry, I took you all from lunch. I will answer questions in between.
Thank you so much. Dr. Doyle will be around for lunch or questions. Okay. So we'll start 12:20 again. I think we'll shave 5 minutes off. And I hope we have good gastric emptying times. See you in a few minutes. Lunch will be in the lobby.